So, good afternoon, everyone. Welcome to this ESICM webinar on respiratory drive and effort in daily practice. My name is Leo Heunks. I'm a pulmonologist intensivist at the Radboud University Medical Center in Nijmegen, the Netherlands, working as clinician and scientist with specific interest in mechanical ventilation, the impact of mechanical ventilation on the respiratory muscles, and lately also in respiratory drive. And I think this is a very interesting entity, both from a clinical perspective and from a scientific perspective. The physiology of respiratory drive is really complicated. It is generated in the respiratory centers in the brainstem. It results in a respiratory effort, but quite often at the bedside, I don't really understand why a patient would have a very high respiratory drive or why sometimes the drive or effort is low. But we all know the clinical relevance. On the one hand, we all recognize if the patient has a very low or absent respiratory drive, this patient is at risk for respiratory muscle atrophy. But on the other hand, if respiratory drive is high, respiratory effort is high, this patient may be at risk for lung injury, PCLI. Patient may be at risk for diaphragm injury, myotrauma, may have high dyspnea sensation. So this is a very important topic from a clinical perspective, especially in patients on non-invasive ventilation, patients on high flow, or on the other hand, in patients in the transition phase from controlled to assisted ventilation. So if you're here listening and watching the slides later on, even if you're a clinician, if you're a scientist, this is going to be a very, very interesting session. And I'm so happy that we do have three great speakers who are going to discuss the physiology of respiratory drive, bedside techniques to quantify drive and effort, and how are we modulating respiratory drive at the bedside. And it's my real pleasure and honor to introduce our first speaker, which is Domenico Grigo. He is intensivist from the Department of Emergency Medicine, ICU, and Anesthesia in Rome, Italy. Despite the fact he is still very young, he has published a couple of very interesting papers in this field. A recent paper on the effect of setting PEEP on respiratory drive. He has fantastic papers on helmet NIV, inhaled nitric oxygen, awake prone positioning. I mean, it's a really interesting CV. So I'm very happy to introduce him for this webinar. And he's going to talk about respiratory drive and effort, the physiological aspects. Please, Domenico, go ahead.
Thanks, Leo, and thanks to the ESICM for organizing and inviting me. And good afternoon, ladies and gentlemen. In the next few slides, I'll try to discuss the pathophysiology of respiratory drive and effort, mostly focusing on the consequences on the lungs and the diaphragm, which is the part that we are mostly interested in terms of lung and diaphragm protection. These are my conflicts of interest, nothing specifically related to the topic we are discussing today. And I will start with this essentially classical slide, in which that summarizes essentially what Leo was mentioning, so that the brain centers generate the neural respiratory drive to respond to the stimuli coming from mechanical inputs that can come from the lungs, brain inputs, inflammatory inputs, and biochemical inputs. Essentially, what mostly drives the drive and the effort is CO2 in most patients, in healthy subjects. So increases in pCO2 increase the drive, and this increases the effort. The drive is the neural stimulus that is produced by the brain that reaches the respiratory muscles, and the effort is the mechanical output in terms of muscle function of this neural stimulus. And they are usually coupled in case there is no diaphragm dysfunction or respiratory muscles dysfunction. But unfortunately, in some patients, the relationship between the response to PCO2 in terms of needed ventilation may vary, meaning that some patients start to breathe to reach a different PCO2 target. And this can happen and in patients with ARDS, for instance. Some patients with ARDS start to breathe, reaching a PCO2 target that is often lower than the normal PCO2 that we are used to having as healthy subjects. And this obviously increases respiratory drive and increases muscle effort. And one should ask what happens to the lungs and the diaphragm while we start to breathe at inspiratory effort and with a high respiratory effort, high inspiratory drive. Well, this is a classical study coming from Mascheroni and published in ESICM in 1988. So in this study, it was very nice because it was the first description that hyperventilation could be harmful. Essentially what they did, they took the animal model, they induced acidosis in the cephalorachidian liquid, and they assessed the response. And essentially, they noted that this generated, obviously, lower pH in the brain, essentially, increases the respiratory drive, which increases the inspiratory effort, which increases minute ventilation. So these subjects started to breathe with a high minute ventilation, high inspiratory effort. And what they realized that after a while, this was associated to worsening oxygenation because of lung edema. And this actually was the first description of what we know today as self-inflicted lung injury. And obviously, self-inflicted lung injury occurs because of several reasons. First, there is a reason related to the total pressure that we apply to the lungs. That when we are spontaneously breathing, it's not solely the pressure applied to the airway opening as the ventilator does, but includes the pressure that is produced by inspiratory muscles. So if normally a patient breathes with a 5 centimeters of water of negative deflection in the pleural pressure, if you add on top of that 10 centimeters of water, for instance, with pressure support, you will generate a total pressure acting on the system, which is a kind of transpulmonary driving pressure, not properly a static one, but it's really related to the total pressure that you apply to the lungs that is close to 15. But if the patient starts to breathe with minus 20, for instance, with a strong inspiratory effort, and whether you put on top of that 10 centimeters of pressure support or not, even if you leave the patient breathing, the total amount of pressure that acts on the lungs is really high. In this example, reaches 30 centimeters of water. But we have to bear in mind that the lungs is in the thorax. The lungs are in the thorax, and being in the thorax contribute to the hemodynamic equilibrium, and there is a vascular equilibrium at the level of the lungs. And the vascular equilibrium, so the amount of water that is filtrated through the lung capillaries, depends on the relationship that exists between the intravascular pressure, in this example, for instance, 12 centimeters of water, and the interstitial space. The interstitial space of the lungs reflects more or less the pressure that is in the pleural space. So this is an example in which we have controlled mechanical ventilation, muscle paralysis, and you see clearly that the pleural pressure is slightly positive because of the weight of the lung and because of the absence of inspiratory muscles. And obviously the pressure that pushes the water from the intravascular space to the interstitial space will be 12 in this example minus 10. So 2 centimeters of water or millimeter of mercury. But if a strong inspiratory effort exists, what happens is that the total pressure acting across the vascular system, so the transvascular pressure, will increase. because it will be 8 minus 20, which makes 20 of transvascular pressure. And this condition favors, because of the Stalling law, the presence of hydrostatic pulmonary edema. So we have a condition in which there is inflammatory edema, which activates in a way or another that we still do not know perfectly the reason why, activates the respiratory drive, increases the effort worsens the edema, adding on top of the inflammatory edema, the hydrostatic edema, compliance goes down, lung volume goes down, oxygenation improves, and this is a vicious circle. And then there is another issue which has been understood in the last years, which is related to the heterogeneous transmission of the inspiratory effort across the lung tissue. What actually happens is that lung areas have a different behavior, which can be fluid-like or solid-like. Essentially, the different areas of the lungs transmit the inspiratory effort in a different manner. So there are areas where the inspiratory effort is strongly transmitted because there is edema, there is consolidation, this is atelectasis, and there are other areas in which the inspiratory effort is less strongly or lately transmitted. And this obviously generates a pressure gradient between different lung areas at the very beginning of inspiration. And this pressure gradient generates a shift of the gas from non-dependent to dependent areas of the lungs. And if you see here, this is an example that tries to depict what I just tried to explain, that clearly shows that this is a tracings of airway pressure, flow. So you see here the decelerating flow, the positive pressure during pressure. This is a kind of pressure support. And this is the inflation of the different areas of the lung. So ventral, mid-dorsal, and dorsal. So this electrical impedance tomography. And you clearly see here that at the very beginning of inspiration, there is a air coming out from the ventral areas and going to the dorsal areas. And this is the same condition on the right, but with muscle paralysis and controlled mechanical ventilation, the same tidal volume got from the ventilator. But you clearly see that this mechanism is completely abolished. And the big difference is that there is a huge difference in the inflation of the dorsal areas. Essentially, this mechanism, which is called Pendeluft, generates a overdistension of the dependent part of the lungs. And you see here, this is a slide from Takeshi Yoshida and Marcelo Amato. You see here how heterogeneous is the inflation of the lungs in the presence of Pendeluft, with air starting to inflate the dorsal part and only at the end of inspiration inflating the ventral part. And you clearly see here how different in the inflation pattern is when the subject is paralyzed and undergoes completely controlled mechanical ventilation. And this is why, and I find it very interesting, in studies addressing the role of spontaneous breathing, there is a big difference between self-inflicted lung injury and ventilator-induced lung injury. Because there is no full agreement on this, but this is a PET scan and an inflation pattern with the electrical impedance tomography. And you see here that the most overinflation produced by spontaneous breathing is in the dorsal part of the lung. And so it is here the inflamed part. So we have to change a little bit our mind because we are thinking of the baby lung. And usually when we treat ARDS patients, we know that the aim is to protect the baby lung, which is the ventral part of the lung, from ventilator-induced lung injury. So to avoid overinflation of the ventral part of the lung. And you see here that actually because of this mechanism, including Pendeluft, we have an inflammation and overinflation of a region of the lung that is slightly different, which is the dorsal part of the lung. And this is the big difference between self-inflicted and topographical difference between self-inflicted and ventilator-induced lung injury. So taken together, these concepts demonstrate that because of these reasons, patients with a strong inspiratory drive causing strong inspiratory effort can be exposed to the risk of self-inflicted lung injury, which is a comprehensive phenomenon indicating the sufferance of the lungs because of the strong inspiratory effort of the patient. And this, as mentioned before, generates a vicious effort that starts to perpetrate. But obviously, we know that spontaneous breathing is very useful sometimes on the bedside. So in most patients, it is the preferred mode of ventilation. And there is a strong effort in trying to understand what patients are most exposed to these risks, so this the risk of self-inflicted lung injury. And you see here, this is a classical study by Takeshi Yoshida, in which they actually assess the effect of spontaneous breathing in two different degrees of lung injury. And you see here that presence of spontaneous breathing in case of mild lung injury is really beneficial on the lungs. And we know it can be beneficial on the diaphragm because we keep diaphragm working. But if you add spontaneous breathing on top of severe lung injury, you see that spontaneous breathing clearly worsens lung damage. And this is really important to understand in a wider concept, that the fact that as far as we can, so if there is no risk of self-inflicted lung injury and the respiratory effort is low, or the hypoxemia is mild to moderate, it is really wise to keep the diaphragm working to avoid muscle disuse. But if the inspiratory effort is low, to avoid the damage related to self-inflicted lung injury and also to the diaphragm injury caused by strong inspiratory effort that have been reported in research and clinical practice, maybe it's wise to consider some treatment of this strong inspiratory effort. And this is well depicted in ARDS patients by a recent analysis of a randomized trial published by Beidorf-Cassis and the group from Boston. And you clearly see here how I like this study because you see here in the Kaplan-Meier that both low drive and high drive are associated with worsened survival compared to a normal respiratory drive. Then we will see with Irene with what we mean for moderate, low, and high respiratory drive. So just to show that the high drive and high effort can be associated to a worse outcome, so low drive and low effort, and with the best condition would be to keep a physiological condition of moderate drive. Just to highlight what's shown by mentioned by Leo before, this also involves patients with acute hypoxemic respiratory failure undergoing non-invasive support. This is a classical study by Tonelli, in which the inspiratory effort as the esophageal pressure inspiratory swing was recorded before NIV start and after 3 hours. And you see here that the response is really heterogeneous among patients. There are patients that increase the effort, there are patients that reduce the effort, so there is no consistent response in all patients. But if you are going to separate patients that are going to fail the treatment, so consider those with most severe disease, most at risk of self-inflicted lung injury, you see here that all these patients maintained a very high effort after 3 hours of treatment. Differently, essentially all patients that reduced the effort below a threshold value in this study was quite high, which is 20 centimeters of water in inspiratory effort, up into success, non-invasive treatment, and avoid intubation during the stay in the intensive care. My last slide, which is really provocative, and because I love this study, we are learning more and more in the last years, and now we are also understanding that in hypoxemic patients, also expiratory effort can contribute to lung injury or to a change in the respiratory condition. This is a study published by the groups of Marcello Amato and Giacomo Bellani, in which they demonstrated that the recruitment of the expiratory muscles, and you see here this increasing pressure during expiration in the gastric pressure during expiration. So the recruitment of the expiratory muscles in some patients with ARDS reduces transpulmonary pressure and reduces lung volume. So what happens is that if you see here, this is reverted as a mechanism of demonstration. This is the time in which we have the tracings with the plethysmograph, airway pressure, esophageal pressure. This is the inspiratory effort, so the negative deflection in the inspiratory pressure. This is the gastric pressure with the recruitment of the expiratory muscles represented by this increase in the pressure during expiration. And this is the electrical activity of the diaphragm representing the drive. And you see here that after the provision of neuromuscular blockade, obviously you abolish the activity of the expiratory muscles. And this is associated with an increase in end expiratory lung volume. So it's very common in the clinical practice that we see that we sedate and paralyze patients, oxygenation is improved. This may depend on the presence of expiratory muscle recruitment. We don't know why this phenomenon, how common it is, but we know that this may contribute to a reduction in lung volume and worsen respiratory drive. So this takes to my conclusion. Inspiratory drive and effort may be often dysregulated in critically ill patients. Let's say that high drive and high effort expose the patient at risk of self-inflicted lung injury and diaphragm injury, even if global tidal volume and transpulmonary pressure are within safe ranges, because this is related mostly on the pendulum phenomenon. Low inspiratory effort and drive injure the diaphragm due to muscle disuse. Low drive and low effort are also associated to a worse outcome. This is something we need to avoid at the bedside. I did not mention in a Kaplan-Meier before because it's really difficult to objectivate, but high inspiratory drive and low effort usually reflect a poor response of the respiratory muscles to the neural stimulus, which usually reflect muscle weakness. We are learning that expiratory effort, which is a condition known in COPD patients, may additionally contribute in a way or another to lung damage by exacerbating lung volume loss. Thank you very much.
Thank you very much, Domenico, for this excellent presentation. I'm sure there are questions from the audience, and you can ask your questions in the chat, and we will have a discussion with all three speakers at the end of this session. So please, if you do have any questions, drop them in the chat and we'll address them later on. So now it's my honor and pleasure to introduce Dr. Irene Telias, originally from Argentina, but now working in Toronto as clinician and scientist. I'm sure you all know her famous work on P.1, which is really a landmark paper, but she did a lot of great work, other great work as well. And I'm happy she's now going to present about bedside techniques to monitor drive and effort. Please, Irene.
Thank you very much, Leo, for this kind of introduction, and the ESICM acute respiratory failure section for inviting me to talk about what are the bedside techniques to monitor drive and effort. My overall idea is to give you a general overlook at what are the available techniques, and then focus on the ones that I think we should use on every patient in the ICU at the bedside. So as an overview and just focusing on the monitoring aspects, so as Domenico said, and Leo, respiratory drive is the output of the respiratory centers that control the magnitude or intensity of inspiratory effort. And from a monitoring perspective, it's important to understand that the regulation of respiratory drive differs slightly from the regulation of respiratory rates. So whenever we monitor respiratory drive, we have to dissociate from monitoring respiratory rate, and also when we are intending to modulating them. And because of this close relationship, measures of inspiratory effort can be used to estimate respiratory drive, and some measures that are primarily related to the respiratory drive can be used to estimate inspiratory effort. However, there is a big caveat in the ICU that was already mentioned by Dom, is that when you have respiratory muscle dysfunction, you can have some patients where you have a high respiratory drive, but a relatively low inspiratory effort. And you have to keep this in mind because we are normally or usually using measures of inspiratory effort to estimate the states of your respiratory drive. 2 words about why we have to measure respiratory drive and effort. The first one already mentioned, so both over assistance with low drive, low effort, and under assistance with excessive drive and effort are frequent, and both situations can lead to lung and diaphragm injury and injury to other organs, for example, the brain, the kidneys, etc. The other big reason why we need to monitor respiratory drive and effort is because when we look at a ventilator screen, the regular parameters that are displayed on the screen do not tell us anything, or they barely tell us anything about what's the patient's respiratory drive and effort. This patient on pressure support with a respiratory rate of 14 and a tidal volume of 700, we look at the waveforms, we have no idea what's the status of respiratory drive. I can guess because I'm a physiologist, but we don't know for sure. So there's something that we see on the ventilator screen, which is just the tip of the iceberg of the overall pressure applied to the respiratory system. But there's a whole part that it's occult, that it's not seen, which is the negative pressure generated by the respiratory muscles. And we have to go and look for it. Okay, so I like to think of topographically where we what are we specifically measuring when we are using any of the monitoring techniques, because each monitoring technique will give you a slightly different information, okay? So if we start at the respiratory centers in the brainstem, unfortunately, we don't have a direct way of measuring what's their activity, okay? That the neural activity is transferred through the different nerves, the most important one being the phrenic nerve that innervates the diaphragm, and we cannot measure the activity of the phrenic nerve. What we can measure, the first measure from an anatomical perspective, is the electrical activation of the diaphragm, okay, or usually called EDI. How do we do that? So if you see the small diagram here on the upper left corner of the screen, this is the screen of the ventilators, the Getinge ventilators that provide the opportunity to measure this electrical activity of the diaphragm. You insert a catheter that has electrodes close to the tip. The catheter can be oral or nasogastric, goes through the lower third of the esophagus, and it crosses the orifice next to the diaphragm. So what that catheter measures is the electrical activity surrounding the catheter, and the sensors or the ventilator has an algorithm to filter out the cardiac activity. So you're left with only the electrical activity, as you see down here. What are the caveats that we need to know? One, as I said, closest signal to the respiratory center. It is a good surrogate of respiratory drive, but you have to bear in mind 2 things. One is, in order for that being the case, the phrenic nerve function and the neuromuscular function have to be intact. They have to be working. And it gives you a good idea of the drive if the patient is using the diaphragm as the primary muscle. As Dr. Greco had already explained, more and more we're starting to understand how our ICU patients use a lot their accessory muscles, even their expiratory muscles, to assist inspiration. Okay, so when respiratory drive goes high, then there will be recruitment of extra diaphragmatic muscles, and electrical activity of the diaphragm will not tell you anything about that. And it does correlate with inspiratory effort. However, the relationship between electrical activity of the diaphragm and inspiratory effort will vary from patient to patient. But within one patient, you can actually follow very nicely the magnitude of effort if you follow EDI. I just give you 3 examples of patients with low drive and effort. You see low EDI peak, high drive and effort, high EDI peak. So here 5.6, 51. And the other nice thing about this monitoring tool is that it can also help you assess an abnormal patient ventilator interactions. It's a continuous measure, and in this case you can see an intermediate magnitude of EDI, more or less 23, but occurring during exhalation, okay, during reverse triggering. Okay, so once the diaphragm electrically activates, the electrical activation transforms into mechanical activation. Anatomically, what we use to measure that is the diaphragm thickening fraction. Okay, so the diaphragm thickens when it contracts. We use an ultrasound with a linear probe and what we take advantage is this, what we call the zone of apposition, which is a part of the diaphragm that is just next to the chest wall. Okay, we use a high frequency range ultrasound transducer. And here I show you two examples of how would we see in B mode a diaphragm that has a low thickening fraction. This is the diaphragm, two hyperechogenic layers on top of the liver, and barely contracting. And here you see a big contraction. You see now it thickens, and again it thickens. So how do we quantify that? We just put, what we call the M mode. And then we can calculate what we call the thickening fraction of the diaphragm. Okay, how thick the diaphragm becomes during inspiration as compared to the thickness at the end of expiration. Okay, a thickening fraction between 15 and 30%. It's what was found to be associated with the better clinical outcomes in terms of respiratory outcomes, and it happens to be very similar to the thickening fraction of patients breathing at rest. Just to give you some reference values. Okay, so we did all this part while the diaphragm activated, and if we want to measure the overall respiratory muscle activity, as Dr. Gieco said, when we contract our respiratory muscles, what we're generating is a change in the pleural space, in the pleural pressure within the pleural space. What it happens is it generates a negative pressure within the pleural space. And this is what we can measure using esophageal pressure. So we insert again a catheter that has a balloon instead of an array of electrodes. And what we measure is the change in pressure in the esophagus, which correlates very nicely with the change in pressure in the pleural space. If we want to specifically assess the differential contraction of the diaphragm versus the extra diaphragmatic muscles, both inspiratory and expiratory muscles, we have to also insert a gastric balloon. Some catheters do have both gastric and esophageal balloons, so you just put one catheter that has both balloons and you can measure this. More and more ventilators are incorporating these measures, so we might see it a little bit more in clinical practice. The different parameters that you calculate based on a measurement of esophageal pressure, I invite you to visit our Flag Working Group webpage, where we have different videos. We show how to insert the catheter and then how to measure each of the things. The only one thing I wanted to show you related to this is that here on the left is how we see esophageal pressure during passive insufflation. So when we're passively insufflating the thorax, what happens is our respiratory system tries to come back to its resting position. And this is why the pleural pressure increases. This is just the recoil of the chest wall, okay? The gold standard to measure the actual magnitude of the effort is when we measure the change in pleural pressure, as measured by the esophageal pressure, as compared to the expected increase in pleural pressure due to insufflation with the same tidal volume that we are actually having during spontaneous breathing. And this is what we call the muscular pressure, okay? And if we do the integral, we have the really gold standard to assess the magnitude of effort, which is called pressure time product. So all this area overall is the pressure time product that those respiratory muscles are having during inspiration, and correlates with the energy expenditure of the respiratory muscles. And this we can do during synchronous ventilation and also desynchronous ventilation, like reverse triggering. However, all the techniques that we used until now, so electrical activity of the diaphragm thickening fraction using ultrasound, and the insertion of an esophageal or gastric catheters are a little bit time consuming, and we're all very busy at the bedside. So luckily, we have parameters that can be measured directly from the ventilator and are the result of all this pathway until the respiratory muscles contract and with some interaction with the respiratory system or the lung. Okay, And we're going to focus on three techniques. We still have a few minutes left. So two of them are based on what I like to call the airway occlusion principle. Okay. So when we contract the respiratory muscles I already explained, we generate negative pressure in the pleural space. However, when the airways are open, the pleural space works as a compartment that is slightly different than the airways. Okay, and the pressure is transmitted to the airways, but we lose some pressure within this transmission due to the characteristics of the lung parenchyma, etc. When we close the airway, all of the compartments become one big bag, one big compartment. Okay, so any change in pressure in one compartment will directly transmit to a change in pressure in the other compartment, and there won't be any change in flow. There won't be any pressure gradient. Okay, so this is how we see it in our respiratory tracings. On the top we have the flow. Positive is insufflation, negative exhalation. The second recording is the pressure. This is a patient on pressure support, so positive during insufflation. And the last one is the change in esophageal pressure or pleural pressure. Okay, so the patient generating an effort, and therefore there's a negative deflection in the pleural pressure. So when we perform an occlusion, so stir flow, the patient does not know that we did this occlusion and continues to breathe spontaneously and perform an inspiratory effort. Okay, this negative deflection in pleural pressure generates a negative deflection in airway pressure because the airways are closed. So this is a way that we have to measure the change in pleural pressure without having an esophageal catheter. Okay, we are really measuring, by measuring the change in airway pressure, we are really measuring what's happening in the pleural space. Okay, and from this maneuver, we can extract two parameters. One is called P.1, or the airway occlusion pressure, or P0.1. It's the drop in airway pressure from this initial start of the effort until 100 milliseconds and after the beginning of the effort. Okay? And this little portion of the breath correlates really, really tightly with the output of the respiratory centers, what we call the respiratory drive. The higher drive, the steepest this initial portion, and therefore the biggest is the P.1, and the lowest our respiratory drive, the shallower will be this initial portion of the breath, and therefore the lower the P.1. Okay. What's the nice thing about this parameter is that even if we get this occlusion, the occlusion is not perceived by the patient until 300 milliseconds of the occlusion. So therefore, these first 100 milliseconds are really not influenced by the reaction to the occlusion. Okay. The second parameter that we measured is called delta POC, or currently we're calling it POC, which is the change in airway pressure during the full breath occlusion. One big caveat is this is not the maximum effort that this patient can do, which is usually sometimes confusion within clinicians. This is just the change in airway pressure during the unnoticed occluded breath. Okay. One more thing I wanted to show you from this slide is that the change in esophageal pressure during the occlusion is much larger than the change in esophageal pressure or pleural pressure during the unoccluded breath. And what we are really trying to estimate is what is the effort that the patient is doing during the unoccluded breaths. Okay. So we will have to work our way around correcting this change in airway pressure to really try to estimate what the patient was doing without the occlusion. Why does this phenomenon occur of having a stronger effort during the occlusion? One, then the most important, the diaphragm works in a more efficient condition when the airways are occluded. And the second is some patients do react to the occlusion. So 2 more minutes to finish. So the first thing about P.1 is different ventilators measure P.1 in a different way. So one is you activate a maneuver. The maneuver performs a very short occlusion, and they do actually measure the P.1 during the occlusion. Other ventilators provide you a breath-by-breath value. What's the caveat of this? They just using the drop in airway pressure during the trigger phase to estimate what will be the drop at 100 milliseconds. But there's no true occlusion, and therefore high values might be underestimated. So you might get a low value despite the patient having a high drive. So we did our validation of the values directly displayed on the ventilator screen, and we found several things. One is that the values directly displayed on the ventilator screen really correlate with gold standard measures of respiratory drive, so the rate of increase in electrical activity of the diaphragm and inspiratory effort. And more importantly is that we can use these values to also estimate inspiratory efforts, okay? When we get extreme values of P.1, very low values, less than 1 centimeter of water, really correlates with low inspiratory effort per minute, and very high values, more than 4 centimeters of water overall, with a high inspiratory effort per minute. Later on, other investigators using this value directly displayed from the ventilator have found that P.1, particularly high values of the P.1, correlate with clinically important measures. One is 90-day survival. When they measure P.1, the first day the patients are able to communicate somehow. And other investigators shown that P.1, on the day you transition to a spontaneous mode of ventilation, predicts failure to transition to mechanical ventilation. POC, what's the difference with POC? POC is more a measure of effort rather than drive, and it helps you two things. One, to predict the effort during the unoccluded breaths by multiplying this by a factor 2/4. And the other one, which is very important, is to also estimate the total driving transpulmonary pressure. When we correct this value POC to get the change in pleural pressure during unoccluded breaths, and we add the positive pressure given by the ventilator, okay? And just to finalize, the last maneuver that we can do is to do an inspiratory occlusion, also during spontaneous modes of ventilation. In this case, it's a patient on pressure support, and different than what we would have expected, most patients during spontaneous mode of ventilation, if you do an inspiratory occlusion, they will actually relax and you will be able to see a plateau pressure, okay? How does it help estimating the magnitude of inspiratory effort? The difference between the peak pressure without the occlusion and the plateau pressure with the occlusion is an estimate of what was the contribution of inspiratory muscles to the overall driving pressure. Okay, so the difference between this plateau pressure and the peak is what we call pressure PMI, pressure muscle index. And if we measure the difference between plateau and PEEP, we can estimate the static driving pressure. The last one, what's the caveat, is that many times you don't have a true plateau pressure. So please, if you see something like this, the plateau going up, 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 don't use this as an estimate of a real plateau pressure during assisted ventilation, neither if it goes down. And with this, I thank you very much for your attention, and I hope you have many questions so that we can address them.
Thank you so much, Irene, for this enthusiastic and very clear talk on a very complex topic. I already saw that there's a lot of questions in the chat, so we're going to address them later on. But first, it's my pleasure to introduce Annemijn Jonkman from Erasmus University Medical Center in Rotterdam, the Netherlands. She's an expert in medical technology, has published a lot of papers on advanced respiratory monitoring, including esophageal pressure monitoring, EIT. And now I'm very happy that she's going to discuss how we can modulate the respiratory drive in our patients on the ventilator. So please, Annemijn, go ahead.
Thank you so much to the ESICM for inviting me to do this presentation. So I have some disclosures of research funding. And in this talk, I will focus mostly on the why and how we can modulate respiratory drive. We have already learned what is respiratory drive, how can we monitor it, but how can we actually adjust or modulate respiratory drive at the bedside? Because there's more and more evidence that we have to target a lung and also diaphragm protective mechanical ventilation. And 2 very nice papers were published to discuss these strategies. How can we protect the lung and the diaphragm by modulating the respiratory drive? When we modulate respiratory drive, we want to minimize the lung stress and strain on the lungs, but also optimize the diaphragm effort and the synchrony. And Domenica already nicely explained the concepts about P-Silly and diaphragm injury, so I will skip this part for a bit. So increased respiratory drive may result in pendulifts in high tidal volumes and increase in lung stress, which can then lead to worsening lung function. So we have to modulate respiratory drive, both for lung protection and also for diaphragm protection. With regard to lung protection, this study nicely showed that when a patient has severe lung injury, plus spontaneous efforts, that this can even worsen lung injury. On the other hand, we could modulate respiratory drive to protect the diaphragm. And this nice review paper summarized that both a low respiratory drive and high respiratory drive could lead to diaphragm weakness. When the respiratory drive is very low, this could lead to diaphragm atrophy, thereby weakness. On the other hand, when respiratory drive is very high, this could maybe lead to disruption of the diaphragm sarcomeres and to injury of the muscle. And I also like this summary showing that different components can affect lung injury and diaphragm injury, whereby a patient ventilator asynchronous, resulting from either low drive or high drive, can have worsening effects. So how can we then modulate respiratory drive? In our review paper in ESICM, we made this kind of pathway, because respiratory drive is affected by different inputs, as Domenica also nicely explained. So we have stimuli from the brain, chemoreceptive stimuli, and also mechanical stimuli. And different methods are available to either impact these components of the respiratory drive. And I will focus on how we can modulate ventilator settings to titrate respiratory drive or sedation. And there are also some experimental strategies like extracorporeal CO2 removal, or more in the line of affecting respiratory effort, we could either use partial neuromuscular blockade or muscle stimulations. So sedation, of course, has an effect on respiratory drive. Depending on the type of sedation that you use, you can either affect respiratory effort by lowering the effort or by affecting mostly the respiratory rate. And I will focus mostly on how can we use simple titration of the ventilator to affect respiratory drive. We know that inspiratory pressure and flow can affect respiratory drive because when we increase ventilator pressure during inspiration, we may lower respiratory drive. And this is due to 2 main pathways. First of all, when we increase inspiratory pressure of the ventilator, we increase our minute volume. That way we can lower our CO2, which is lowering respiratory drive by the chemoreceptive pathway. On the other hand, when we increase inspiratory pressure on the ventilator, we put more stretch on the chest wall and on the lungs. And there are some chest stretch receptors that then give a stimuli to the brainstem, lowering respiratory drive. And this nice study showed that different inspiratory assist levels can affect respiratory drive, shown as follows. Here we have an example where a pressure support level of 7 centimeters of water was given. We see esophageal pressure swings and diaphragm electrical activity. But when inspiratory assist is increased, in this example to 25 centimeters of water, we see almost no diaphragm electrical activity and no negative deflection in esophageal pressure. Actually, this patient is not triggering the ventilator at all. This is just a passive breath because we see an increase in pleural pressure during inspiration. And in the study, they nicely showed that when we increase our pressure support level, the muscle pressure of the diaphragm is going down. And this is mostly because of this Heering-Breuer inflation inhibitory reflex. When we increase our pressure, the respiratory drive gets a signal to lower drive. But this works mostly when the respiratory drive is stimulated mostly by CO2. When respiratory drive is very high because of other stimuli, agitation, pain, or a lot of inflammation, this reflex is overwhelmed, and this effect is much more challenging to get or to see at the bedside. We actually use these methods in a feasibility clinical study in 40 patients with respiratory failure in pressure support mode, where the intervention was that we titrated inspiratory support every hour to obtain actually diaphragm pressure within a predefined diaphragm protective range, so a range of moderate effort. And the control group was standard of care. And this trial was led by Hede de Vries, who is going to actually defend his PhD thesis tomorrow morning. And he nicely showed, he did 24 hours measurements, and every hour he titrated the ventilator support. And he found that it was very feasible to titrate the effort of a patient within the diaphragm protective range that we defined in most of the breaths. So in the intervention group, we found over this 24 hours that we could get about 75% of breaths within this diaphragm protective range. While in the control group, which was just standard of care, this percentage was much lower. In addition, titrating inspiratory assist did not result in higher tidal volumes or higher transpulmonary pressures. So then let's talk a little bit about PEEP, which I think is a bit more complex. PEEP mostly gives a mechanical stimuli to the lungs and diaphragm, thereby having a variable effect on respiratory drive. And I will try to summarize this. When we apply PEEP to our patients, we place the diaphragm in a more caudal position. We get a flat diaphragm dome, a shorter muscle in the zone of apposition, and this is suboptimal for the diaphragm. Often the diaphragm can generate less pressure because of this suboptimal position for tension generation. However, the effect on respiratory drive is quite variable, depending on a few things. Let's discuss a few studies. This is a project that we did a couple of years ago in healthy volunteers. We applied PEEP during a non-invasive ventilation, and we made some MRI scans. And you can very nicely see that when you apply PEEP, the diaphragm is placed in a more caudal position, and also the zone of apposition is getting shorter, so the diaphragm is less efficient. We also measured the EDI of the diaphragm, the electrical activity, and indeed we found that the neuromechanical efficiency of the diaphragm was reduced with higher PEEP levels. This is a study in patients, but also in animal models, where you can clearly see here, you see airway pressure tracings of a representative patient, esophageal pressure swings. By increasing PEEP, there is a decrease in the swings in esophageal pressure. So higher PEEP resulted in less the effort of a patient. In the animal model, they also found that higher PEEP with spontaneous breathing resulted in a lower lung injury score on CT scan. So high PEEP and spontaneous breathing efforts resulted in less injurious lung mechanics. So PEEP can be protective maybe with a patient that is spontaneous breathing by lowering the respiratory effort. Then there was a very elegant study by the Toronto group who tried to implement strategies for lung and diaphragm protective ventilation in ventilated patients with acute respiratory failure. But they actually found that the effect of modulating PEEP on inspiratory effort was dependent on the effect PEEP had on respiratory mechanics. So PEEP only resulted in a lower inspiratory effort when applying PEEP resulted in a better lung compliance, thereby also lowering the transpulmonary pressure in this subgroup. So the effect of PEEP on effort and thus on lung stress differs according to whether the patient is recruitable, yes or no, and whether there's an improvement in lung compliance. This was also recently very nicely showed by the group of Domenico in this study in chest, where in 16 patients with a PF ratio below 200 millimeters of mercury and higher inspiratory efforts at baseline, which was defined as more than 10 centimeters of water, they applied pressure support ventilation and tested two PEEP levels, 5 and 15, in a crossover setting. And they found when they looked at a change in inspiratory effort from 5 PEEP to 15 centimeters of water PEEP, there were basically variable effects seen. For some patients, the effort decreased with higher PEEP levels, but for some other patients, it actually increased. And this change in effort due to PEEP was driven by the effect of PEEP on respiratory compliance. So they found that PEEP decreased the effort of the patient only when it resulted in a better respiratory system compliance. So to summarize this part, I think it's very feasible to modulate respiratory drive by simply changing some ventilator settings. When we give higher inspiratory support, we can reduce the respiratory drive of the patient. But, what I said before, this can be difficult when this Heering-Breuer inflation inhibition reflex is overwhelmed, either because there's a high respiratory drive related to other stimuli, like pain or inflammation. Second, we talked a little bit about PEEP, and higher PEEP can reduce the respiratory drive of the patient when PEEP results in a better respiratory mechanics. So there's a more homogeneous distribution of the tidal volume, there's a better gutter change, thereby also affecting the PaCO2 and thus respiratory drive, and it can reduce then the regional lung stress. The other pathway by which higher PEEP can reduce the respiratory drive is by placing this diaphragm in a less optimal position for tension generation. As I explained earlier, this caudal position with the shorter muscle is less able to generate tension. So then how to modulate respiratory drive if adjusting sedation or ventilated pressures do not work out? Then there are some experimental techniques like adjusting the PaCO2 by extracorporeal CO2 removal. And if that does not affect respiratory drive enough, there are some other experimental techniques, but those are mostly targeting the respiratory effort of a patient. So there's partial neuromuscular blockade, but this really requires good monitoring of the drive and the effort because you are partially paralyzing the patient, which also affect hemodynamics, for instance. So only under close monitoring of the patient, this is still an experimental technique. Other techniques are mostly in the line of low respiratory effort. So if the diaphragm or other expiratory muscles are not generating enough effort, then there are some experimental techniques to stimulate these muscles, either through the pacing of the phrenic nerve to activate the diaphragm. And there are some studies going on now to stimulate the expiratory muscles using electrodes placed on the abdominal wall. But these are experimental techniques in patients where there is a very low respiratory effort and we want to optimize this effort to prevent atrophy and weakness. So then we always have to question, what are the targets? What are the targets for diaphragm protection? And I put this table from the paper of Ewan Golliker in 2020 in the Blue Journal, where there are some potential therapeutic targets, depending on whether you want to prevent over-assistance or under-assistance and what kind of monitoring technique you use. So depending on the monitoring technique, there are some potential therapeutic targets, for instance, a P0.1, targeting above 1.5 centimeters of water, maybe prevent over-assistance diaphragm myotrauma trauma, but a higher occlusion pressure, on the other hand, should be avoided to prevent under-assistance diaphragm myotrauma trauma. But all these targets are mostly based on physiological reasoning, And we need more prospective clinical studies to really test what are good strategies for diaphragm and lung protection. But I think the most important part is that we have to be aware of the effect of high drive and high effort on both the lungs and the respiratory muscles. So my talk was mostly based on these two papers. So if you want to have a better read-through, to go more into details, I would recommend to look up this work. Thank you very much for your attention and again for the invitation to do this presentation.
Thank you very much, Annemijn. We're a little bit behind schedule, but this is not a problem. ESICM gave us 10 more minutes, so we do have time for some questions. There have been great questions in the chat. Thank you very much for that. And maybe, Irene, I can start with a clinical dilemma. Sometimes we have this patient on an assisted mode, say pressure support, ventilation. He's actually doing quite good, tidal volumes around 7 ml per kilogram. I'm doing the measurements as you propose, and now both P.1 and occlusion pressure are high. Say P.1 of 5, occlusion pressure of 16. So what is your approach in this patient?
So the first thing is that the values that you provided are high, but are not crazy high.
Okay, I'm gonna drive you crazy, Irene. I'm gonna drive you crazy.
Okay.
Focus 25.
Okay, perfect. So the interesting thing about PIOC and
it's an important clinical dilemma, right?
Yeah, totally. So the one thing, so that people can just to review a little bit of what I presented. The nice thing about PIOC is you not only have the PIOC value, but you can also estimate the total driving pressure. So you said the patient was on pressure support, was receiving some positive pressure ventilation. So I don't remember what was your last number. I think 20 of PIOC. Let's say 2/3 of that. I cannot do the math on my brain, but let's say around 15, I think, or a little bit more,
yeah.
plus whatever positive pressure. So let's say the patient was on 12. So 15 plus 12, 27 of total driving transpulmonary pressure, which is a dynamic pressure. We don't know the threshold, but we think that more than 20 to 23 is equivalent to the 15 driving pressure during static passive mechanical ventilation. So really high. So the clinical dilemma is having this patient has high drive, high effort. So we have a diagnosis. The second question that I always ask myself is why? From a clinical perspective, is this an indication that there's any clinical problem going on? And so first investigation, address the clinical problem before making any decision. Second, are the ventilator settings appropriate for that person in terms of the amount of support and the timing of the support and the mode? Is that patient comfortable in terms of their own breathing pattern versus whatever you're providing? So that would be my second step. And just as Annemijn has said, the third thing would be, is this potentially harmful for the patient, or is actually the patient's trajectory getting better, despite these strong efforts? And in parallel, does this patient fulfill criteria for readiness to win? And should I do actually a spontaneous breathing trial and just take that tube out? The classical situation is, for example, a patient with agitation and discomfort because of the breathing tube. Okay, so that patient is getting better, and the etiology of the high drive, high effort is actually agitation, delirium, discomfort. And then for the actual treatment, it's just to remove the tube. So, and this is a paradigmatic case. So we don't know if we need to modulate the drive in terms of clinical practice. So if it's worth giving, for example, sedation, if all the things I did that Annemijn taught me failed, because there's a potential risk of harm because of the sedation. What we know for sure from clinical trials is that we have to wean and extubate the patients as soon as possible. So while we are doing all this thought process, we have to think, is this patient ready to be liberated? And therefore, at least we're not exposing the patient to be at risk of injury. If the answer is the etiology of the high drive is a new pneumonia, and the patient today it's a little bit worse than yesterday in the context of the high drive, then I might adjust the settings to decrease the drive, and maybe if that's not enough, consider sedation, at least for some time, to modulate the drive and the effort until the patient is a little bit better.
Thank you very much, Irene. I think that is a very important message, right? It's not just about the numbers, it's about the clinical course of the patient as well, because, well, I think we all have heard people just increasing level of sedations based on POC or P.1, but, well, there's an adverse effects of sedation as well, right? So that's a difficult balance that we need to judge as clinicians. So,
and most of our data now, it comes from observational data, and there's a residual confounding related to the use of sedation that is very difficult to adjust for. And so patients with high drive probably are also receiving more sedatives, and it's challenging to adjust, and that might be also driving a little bit the poor outcomes. So we have to be careful.
Okay, thank you so much. There's really a lot of questions in the chat. So I think it's going to be like another 10 hours from now on. No, we're going to finish in time. Domenico, there's a question. So what is the evidence for load-induced myotrauma? I think all the three of you mentioned it, but what is the evidence? Do we really need to take this into account? You're muted, Domenico. Yep.
I'm not like an expert of diaphragm injury itself, but taken together, maybe Annemine can provide some more detailed insights, but taken together, I would think that Irene mentioned that we have to wean the patient as far as possible, and we have plenty of data demonstrating that using assisted ventilation compared to controlled ventilation, avoiding the use of paralysis is very good for the patient. I think we have this data coming from 90s and 2000s about this, but we were not fully aware of the risk of diaphragm disuse. So I think that diaphragm disuse explains those data, or at least contributes to those data. In terms of data directly about diaphragm disuse, we have data clearly from Yuan, for yourself as well, and it is clearly shown that at least if the diaphragm function is less effective, there is a prolonged duration of mechanical ventilation. So I think this is really consistent with what I was saying. And I always think that it's really difficult to strive for a balance when you have to the need to avoid diaphragm disuse and also avoid strong inspiratory effort, because sometimes lung and diaphragm protective ventilation sometimes are the same, sometimes they're really different, because we never want to use sedatives, and sometimes we need to use some short course paralysis to these patients. So I think that as a general rule, generally speaking, I would say that it really matters. Also discussing what Irene was saying, I think one of the other elements that should be taken into account is the timing. So I believe that a very strong inspiratory effort on day one of mechanical ventilation after intubation or during NIV can be really dangerous. Maybe after 25 days or 20 days of respiratory support, we see plenty of patients that are on prolonged mechanical ventilation with some fibrosis. Maybe in that case, the strong inspiratory effort and the high driving pressure, maybe with a normal tidal volume because of low compliance, is only a compensatory response. So, but still, I believe it really is complicated.
Okay, thank you very much. And maybe Annemine, so non-invasive techniques to assess respiratory effort have been discussed, right? The POC, PMI. So do you still think there is a role for the esophageal balloon, esophageal pressure monitoring to assess respiratory effort, or are the non-invasive tools as good as the esophageal balloon?
That's a really good question. I think the esophageal pressure measurements are still very good to use at the bedside. We do it quite often in our patients because when you only look at the P0.1 or occlusion pressure, it's more a screening for high or low respiratory drive and effort. But if you really want to quantify drive and effort, because we also know that if occlusion pressure is, let's say, 20 centimeters of water, the actual effort of a patient, so the actual PMAS, can have quite some variation. So if you really would like to quantify the effort of a patient, we still use the esophageal balloon. But not in all patients. So we use occlusion pressures P0.1 more as a screening tool. But if we really want to quantify, for example, when we suspect diaphragm weakness in a patient, then we use the esophageal balloon to better diagnose it. But first used occlusion pressures, I think, are very appropriate as a screening tool, either for drive and effort, but also to get an estimation of what can be the potential transpulmonary pressure. So what is the stress on the lung?
Okay, thank you very much. That makes sense. I'm afraid we have to close this session. There's a lot more questions in the chat, but we have to close. So I would really like to thank ESICM, Acute Respiratory Failure Section, for organizing this webinar. I'd like to thank the speakers for the excellent presentations, and thank the audience for staying here until the very end. Have a very nice day. Bye-bye.
Thank you. Bye.
Thank you. Bye-bye.